So thanks everyone for joining. My name is Julie Uy. I'm very, very proud to present today's lecture from Jeanie Cheong. So, you know, Jeanie needs no introduction. She's a great friend of mine. We share a lot of laksa together, but, you know, she is famous in the world of neurodevelopment for preterm babies. She is the world leader. She is now currently co-group leader. I'm going to read from her profile of the Victorian Infant Brain Studies Group and the convener of the VIC study, the Victorian Infant Collaborative Study, which has outcomes to like, is it 40 years now, Jeanie? Yeah.
Just 25.
25, just young people, yes. And it's enormous, unique data. So today she's going to present to us how and why we need to follow up babies and talk about the new NHMRC, Australian guidelines or guidance for follow-up of preterm infants. So like all our other Zooms, she'll talk for about 45 minutes or maybe give or take. And type your questions under the chat pane, but we will have some time at the end for questions and answers. So over to you, Jeanie. Thank you so much.
Thanks, Julie, and thanks everyone for giving me the opportunity to present the work to you. So yes, as Julie says, I'm Jeanie Cheong. I'm a neonatologist at the Women's Hospital in Melbourne, and I'm interested in outcomes after the children go home. It's great, isn't it? I need to stop sharing, Julie, because it's not progressing. So whilst everyone is getting very bored, sorry about this, everyone. Can you?
We can see you.
Yeah, you can see me, but what's happening with the PowerPoint? Oh, this is frustrating. All right.
That's all right. Take your time.
I don't usually use this computer.
Okay. There you go. That is action. Yeah.
Is that a full screen though? That's just part of the screen.
That's your PowerPoint. That's not the show.
Is that the show?
No. Yes, this is a show now. Yeah.
All right. Okay.
Good job.
Voila. Okay. We're in business. Okay. So I'd like to quickly acknowledge country. I'm on the land of the Wurundjeri people of the Kulin Nation and pay my respects to elders past and present. These are the points I'll go through today. Many of you who work in the field will be familiar with the need to follow up preterm infants, but I'll just give some background and then launch into the work that we have done as part of the Center of Research Excellence in Newborn Medicine over the last 2.5 years. So why do we need a guideline for follow-up? And for many of you is, why ask this question? We know the answer already. But a few years ago, the team at the CRE in Newborn Medicine put this question to those with lived experience, parents' views, to ask them to identify the research priorities of newborn medicine. And these are the sort of quotes that we got. Lack of information on what to expect long-term, especially in the preschool years. A lot of follow-up studies, we think about follow-ups to 2 to 3 years of age, but there's a life ahead of all these babies. So they felt there was a focus on the NICU, nothing after that, and they didn't really know the issues that were present at birth were going to affect them later on at school. So this is what the team did, and these are the priorities that the parents identified, and you can see that impact on child health and development was up there amongst their important priorities. Now let's talk about the impact of preterm birth. How many are we referring to? So I know I do have an international audience here this afternoon, so I do apologize. This is very Australian-centric. But if you look at Australian numbers from 2022 on the left, total live births in Australia was just over 266,000. 1 in 10, roughly, born less than 37 weeks. And this guideline refers to those born less than 32 weeks, around 1 in 100. And when you look at the proportion of these infants of all live births, we are talking about 14%. As I mentioned earlier, preterm birth is lifelong. For those of us doing follow-up work, when we've looked at every single system, there are challenges, not just in early infancy, in toddlerhood, in early childhood, but also lifelong. And if we are ever going to make a difference to try and optimize outcomes, we need to know what they are. So I'll talk about very briefly about some of the outcomes that we know that's gone into the guideline in terms of what the recommendations are for follow-up. So when you look at growth, we know that those born extremely preterm, you see here EP in the dark line, they're often born lighter and shorter than their term-born counterparts. And this is just taken from a paper we published a few years ago when we tracked the growth of extremely preterm newborns compared with term newborns from discharge until 25. Just concentrate on this shaded area and you can see even up to 10 years of age, the extremely preterm children have still got lower weight Z scores than the term counterparts. So their growth is poorer. What about other aspects of health? So this is from the Millennium Study performed in the UK and summarized in this review by Elaine Boyle and her neonatal fellow. When they looked at the groups by gestational age weeks for wheeze and asthma at 5 years of age, you can see that those born less than 32 weeks, 32 to 33 weeks, 34 to 36, and then 37, 38, there is this gradient. And the odds of having wheeze and asthma, of course, much higher if you're less than 32 weeks. What about hospital admissions? And this is also taken from the Millennium Study. And this is summarizing the percentage of infants who were admitted to hospital for 3 or more times to 5 years of age. And what you see here is you can see in the light blue line for the period between birth and 9 months, and the red line between 9 months to 5 years, and you can see that it does drop off with gestational maturity, but it's still highest if you're less than 32 weeks of age, at gestational age at birth. What about neurodevelopment? So this is a paper led by India Marks looking at some of our Victorian data at 8 years from 3 cohorts. We compared the outcomes at 8 years for the extremely preterm group compared with the term group. On the y-axis are the percentage of children with these challenges, cognitive, so intellect, motor impairment, moderate to severe cerebral palsy, and a composite outcome of major disability that you do see in many research studies and outcomes of trials. You don't have to look at the numbers, you just have to look at the height of the bars, and the height of the light colored bars are much higher than the darker colored bars. So there's more in children with these developmental challenges than their term counterparts. What about data from other parts of the world? So this is a nice systematic review and meta-analysis performed by Pascal et al., published in 2018. They looked at very preterm or very low birth weight cohorts from around the world, included 10 studies. They included more contemporary cohorts and data from just over 10,000 infants. And the consistent message is here: cognitive delay, motor delay, cerebral palsy, there's still a considerable percentage compared with the term controls. Now, outcomes are not just about the children. And if you think about it, children thrive in the environment of their families. So as I've done more and more of the research in terms of outcomes, I always talk about outcomes of the child in the context of the family, and parental mental health is very, very important. From the perspectives of those with lived experience of preterm birth, this domain is an important outcome that should be considered and measured. We know now from many studies that there are more depression and anxiety symptoms in the parents of children born very preterm than full term, not just the mothers, but the fathers as well. And it persists months after the birth, and maybe even longer. If you look at the graph on the right here, on the y-axis again, the percentage of parents who report depression or anxiety symptoms at birth and at 6 months, You see here for depressive symptoms, the light blue line for the very preterm group compared with the dark blue line for the full term, you can see that the light blue line is higher, even at 6 months. And the same pattern for anxiety. What's the status of preterm follow-up in Australia? And this was in 2021 when we started the work. Hopefully it's gotten a little bit better, but we haven't done the survey to see this. So for very preterm live births in Australia in 2021, for those less than 28 weeks, the recommendations from our Australia and New Zealand neonatal network is that children should have a follow-up assessment minimum at 2 to 3 years and 5 years. But the data shows that up to about 20% were lost to follow-up at 2 to 3 years in the 2021 report. And follow-up time points between discharge and 2 to 3 years is really jurisdiction dependent. It's dependent on where you live, which hospital you're at, what state you're in Australia, and what services are available. And certainly if you're born between 28 and 31 weeks, well, there are no formal recommendations. And once again, it depends on where you are and the access to services in terms of what follow-up you get. So with this in mind, we felt that with the support of the CRE in newborn medicine, and the CRE is a grant scheme within Australia where one of the objectives is to promote translation of research outcomes into policy and practice. So this initiative came under that, and we were very fortunate to be able to allocate some resources. And these are the main steps that were taken. We had multidisciplinary working groups, including those with lived experience. There was evidence-based questions to address, and the evidence was looked at from a grade perspective. We had to do public consultations at several stages, and this was launched June last year, 2.5 years after the work started. And now there were some general principles for implementation strategy, and I'll give you an example of implementation actually in our very center here at the Women's Hospital in Melbourne. So these are the members of the guideline team, and some of the slides are courtesy of Dr. Alice Burnett, who was the lead project officer for the first part of this initiative before she went on maternity leave. So we had to have a governance as per the processes of NHMRC, and a few of us sort of listed there with the project officers. And then there was the guideline working group with Professor Katrina Williams, who's the professor of pediatrics from Monash, a developmental pediatrician, and Professor Angela Morgan, who's the professor of speech therapy based at the Murdoch Children's Research Institute and Children's Hospital in Melbourne, and a whole very, very committed group of the guideline working group members from around the country in Australia, from all walks of life, multiple disciplines, and it was really a pleasure to work alongside them. Just to give you an idea of the membership, so every state in Australia, state and territory in Australia was represented. We had one representative from New Zealand. We had members in the working group with lived experience of preterm birth, health professionals from hospital and community settings, including early childhood education and refugee migrant support organizations, and of course, representatives from the First Nations. We took this guideline recommendation to school entry. And why not after that? Well, because it was just not possible and feasible. And I'll show you some data in a minute that really explains why. So what steps did we have to go through? So the first step was that our project officers searched for existing guidelines. One of the easier ways to produce a guideline is not start from scratch, is to look for existing guidelines and to see if we could adapt those guidelines to the Australian setting. The NICE guidelines were from the UK, were probably the most comprehensive available at the time, as well as the European guidelines. But after looking at the details, we did not feel that they were addressing a similar priority that we wanted to address. So we decided not to adapt guidelines, and we decided to develop our own based on the priorities that were set from the Delphi study and also from the multidisciplinary working group. So the working groups were set up. There were clear rules about how this had to be done as per NHMRC processes. Then we had to define the scope. What was our guideline going to include? Age, domains, main questions. This had to go out. This had to be voted on by the working group and then went out for public consultation to then help us finalize the scope. We then had to systematically review and synthesize the evidence using grade methodology and draft evidence statements. There were 8 meetings that we had, and voting had to happen, and we needed, I think, at least a 70% vote to be able to pass important sort of decisions. The systematic review came up with 30,500 studies to be reviewed, and this is really hats off to the project team who worked very, very hard with a very, very short time frame. And then we went on to write the draft guideline, and this was reviewed at multiple points by the working group. And then it also went out for public consultation for comment. And we had to respond to every single comment that we received. And once again, that was a big learning experience for the whole team. So where did we get to in the end? The guideline was then independently reviewed by several reviewers, not just within Australia, but also some international reviews. We had to respond to the reviews and make the necessary edits. We revised that, and then this had to be taken to NHMRC Council, where one of the chairs and myself were there available to answer questions from the council. Fortunately, the questions were addressable. There was general support, and we submitted in March, and the guideline was formally endorsed and launched in June. So a 2.5-year exercise, a lot of resources, but it made me realize how detailed the process had to be if you wanted guidelines at this standard. So enough about the background and the process. So what did we come up with in terms of recommendations? So this statement really summarizes what the group are recommending. So it's a consensus-based recommendations because this is not trial data. It's unlike, some of the Cochrane reviews and recommendations where you have treatment A versus treatment B, and you summarize the evidence from all the RCTs and come up with recommendations that way. This is quite different. But what we felt was that structured, preterm specific post-discharge follow-up care should be offered to children born very preterm and their caregivers. So once again, it's not just the child, it's the child in the context of their environment. And this is regardless of presence of risk and or resilience factors. The guideline, one of the questions that we tried to address with all the evidence was what were the risk and resilience factors for outcomes for children born very preterm. I'll show you a summary of the table later on. It's in the guideline, which is publicly available, and I'm happy to share the link with Julie if any of you are interested to read the guideline in its entirety. The clinical practice points were set out to give people a framework, a minimum set of contact ages and priorities. We wanted to stress multidisciplinary involvement and recognize that follow-up did not necessarily and actually shouldn't happen just in the tertiary hospitals where these children were looked after in the neonatal period. So we had to consider hospital, community settings, universal settings, primary care, absolutely key. Now, much as I hate hated the period of lockdown during the COVID pandemic, it did actually have its silver lining. And one of the important things that it highlighted was the potential value of telehealth. And we also wanted to highlight in the guideline that follow-up did not necessarily have to be in person, face-to-face, and that flexibility was the key, and telehealth modes should be considered when and where appropriate. So if you're ever going to look at one page in the guideline, this is the page I would recommend. So this is the follow-up schedule, the recommended schedule that I have adapted from the guideline. Don't be put off. Don't say, oh my goodness, we can't possibly do this in our hospital. Let me just talk through it with you. And certainly I can speak from the Victorian sort of perspective that quite a few of these time points are already happening in practice. It's really more to sort of say to people, look, these are the important ages, and make sure there's a point of contact, if at all possible. So looking down on the left are the priorities, and we've divided them into physical health, development, quality of life, and the family. And you will see down below family, it's mental health of the caregivers, the parents, their access to resources and information, quality of life for the child and the family, development, include feeding and sleeping, very important factors, in addition to your, classic impression of what neurodevelopment domains encompass. And of course, never forget general health goals and sensory. So first bit is the post-discharge period, 7 to 10 days and 6 weeks. And a lot of this is already provided by primary care health, the maternal and child health nurses in Victoria, and I think probably in a lot of jurisdictions in Australia. Why 7 to 10 days? The parents really, those with lived experience on the working group really highlighted this age as a very important time point. They've just been discharged from hospital, they've had a lot of care, and then suddenly, bang, they're home with very little support. So the 7 to 10 day mark they felt was very, very important. And of course, the maternal and child health nurses usually have a follow-up at this age. 6 weeks as well, of course. A lot of that done in the community by primary health care providers. Then comes the first year. For this, we have recommended at least 3 time points and an extra one at 6 months if there are any particular concerns from earlier visits or from the neonatal period that would deem it preferable to see these children at 3 monthly intervals in the first year. So 3 to 4 months, 6 months, 8 to 9 months, 12 months. And you can see here with the crosses, they are the domains of follow-up that we recommend should be looked at the follow-up visits. Then comes the 2nd and 3rd year and preschool. For the 2nd and 3rd year, if all's going well, we recommend 3 follow-up points, or 2 to 3 follow-up points. You can see here for the 18 months follow-up, if all's going well, you can consider a telehealth check-in. But we do recommend at 24 months an in-person assessment. And for those of us in Australia and New Zealand, the ANZNN recommend a medical assessment to determine health and also a neurological examination to see if the child is demonstrating any signs consistent with cerebral palsy. And of course, developmental assessment, and in many sites in Australia and New Zealand, it's the Bailey 4. 30 months if there are concerns, and now at 4 to 5 years, an in-person preschool visit and a cognitive assessment as a minimum, in addition to other sort of assessments as need be. So this is the recommended follow-up schedule. So if you go back to that initial, oh my goodness, when you saw this chart, what are these guys recommending? You will see that the 7 to 10 days, 6-week time point is already covered by a lot of primary care services already. Many of these children do receive follow-up in the first and the second year, but what we are trying to do is to provide a structure, provide some guidance as to what ages would be appropriate and what sort of areas should be looked at. The 24-month and the 4 to 5 years is already covered in many places as a result of the ANZNN recommendation. So it's all and good, to look at the literature, to look at, tens of thousands of articles and to come up with some recommendations. But if it stops there, it doesn't benefit anyone. Most importantly, our children and their families. So what are the practicalities of implementation? And I just want to share an example because we've been going through this at our very own center in Melbourne. So the Women's Hospital in Melbourne is a tertiary neonatal center co-located with tertiary maternity services, but we have no pediatric service on site. The pediatric services are all based at the Children's Hospital just down the road from here. We were in the process of restructuring the follow-up service, so it was timely that this guideline was launched and delivered, and we were able to restructure based on the schedule recommended by the guideline. Certainly, the guideline meets the recommendations of ANZNN, and for ANZNN, I've alluded to earlier, a Bailey and now Bailey 4, neurosensory assessment, cerebral palsy assessment, and a cognitive assessment at 5 years. Now, with every jurisdiction, there are funding constraints, and after modeling, what we worked out that we could offer was in-person assessments, less than 28 weeks, less than 1,000 grants as per ANZNN, but we did have the luxury of extending that up to 32 weeks as per this guideline. And what we are able to offer right now is in-person assessments at least those ages for the infants with the risk factors. Now, you may be wondering, what risk factors am I referring to? And I'll give you a snippet in the next slide. But how about the 28 to 32 weekers without risk factors? What are we going to do there? Well, we're still sort of having a think about how we get to them, but one possibility with time is to have some questionnaire screening rather than in-person assessments. This is not perfect. It's only a screen. It's not diagnostic, but it is better than nothing. And perhaps if there are concerns from the screening, they get looped into in-person assessments. So certainly this yellow bit is not happening, but it's just a thought and a thought that can be worked towards. What are the risk and resilience factors? So on page 51 of the guideline, this table appears. So I'll just talk you through the table because I've got some time. So these are the risk and resilience factors that will be of no surprise to many in the audience. Gestational age, sex, SGA, small for gestational age, major brain injury, and in many studies defined as grade 3 to 4 intraventricular hemorrhage and or cystic PVL, sepsis, which is defined in numerous ways in numerous studies, retinopathy of prematurity, NEC, antenatal corticosteroids, postnatal corticosteroids, BPD, surgery, seizures, socioeconomic status, that's SES, breast milk or no breast milk, and I don't know what ACE is actually, or adverse childhood experiences, remoteness, and of course, culturally and linguistically diverse groups. All the red sort of marks indicate that this risk factor negatively affects outcome. So you'll see there are a lot of reds everywhere. If there's nothing, it means that there's not enough evidence to tilt the balance either way. And of course, with the green ones, they actually positively affect outcomes. So not surprising, antenatal corticosteroids, better development. Okay. Sam Exford, who's a neonatologist at the Children's, who's doing his PhD, a paper that was just accepted on Tuesday, so I can very proudly say impressed, took this work to a publication and has very nicely gone into greater detail the risk factor effects on neurodevelopment at 2 years, a systematic review of tens of thousands of articles. So I just want to end here. So improving care of preterm newborns, and this is just one aspect of it. In addition to all the amazing trials that are happening in the newborn space and the post-discharge space for improving outcomes, well, we can certainly do more with what we have at the moment. So we've certainly gotten better at keeping these very preterm babies alive, but we still have they're still faced with short and long-term health and developmental morbidities. I think the focus really should be to optimize the outcomes. I don't think we can take them away fully, but let's just get them to the very best that they can. And national initiatives are most impactful rather than, just doing it at your own hospital without sharing the knowledge more widely. Implementation is always a challenge. It needs support from institutional leadership, and I'm very grateful to my own institution for having a lot of the support to be able to restructure our post-discharge care along with the recommendations of the guideline. And of course, with everything, you need money. So does this work just stop here? Not really. So Julie is part of the investigator team as well. We have been fortunate to secure funding for another Center of Research Excellence that started this year, the EPIC CRE, Extremely Preterm CRE. And as part of the translational activities to come, we've got more exciting national guidelines that we hopefully will launch in the next 5 years. I want to acknowledge everyone who has contributed to the guideline. And what I haven't got on this list, which is not possible to list, are all the researchers, all the children, the participants, their families, who have come and been very committed to all the follow-up studies that have been the evidence base behind what I have been able to share with you today. So I'll end here. I'm very happy to take questions. I always believe a short presentation is better than a long one. Thank you.
Thank you so much, Jeanie. You've got some questions online, but I will take advantage of being the host to ask the first question. So in your chart, you had boys sleeping better, is it?
That's very interesting, yes.
Okay, have you seen my son?
It's interesting. Look, the sleep data is not strong. Sleep is not something that is very well studied in the literature in terms of follow-up. So the data is not strong, but sleep is an outcome that is very important from the perspectives of those with lived experience. So I think,
absolutely,
for those of us who have sort of been through sort of looking after young children, you realize how tough it is when children don't sleep. So it's an area I think that certainly deserves more research, but from the evidence that we have so far, boys do better.
Ooh, okay. Well, come to my house. Anyway, we have 2 questions online, and please, guys, just type your questions in the chat page, and or unmask yourself if you want to ask Jeanie the question directly. We'll start off with Brooke first, who asks, where would language impairment fall in these domains?
It's under development. So when you think about sort of neurodevelopment, there's a neurosensory aspect to it, and then it's usually broadly divided into cognitive, language, and motor.
Okay, thank you. And because Anki, one of our nephrologists, has 3 questions or 3 statements, Anki, can you unmask yourself and ask them directly? Because this is a very important question, I think, because we focus on the brain, but we miss those little kidneys. Anki, are you still there?
Yes, I'm here. Hi. Hi, Professor Cheong. Thank you so much for your lovely lecture. My name is Anke. I am one of the nephrologists working with Julie in Randwick. And I am myself 6 months short of being a neonatologist, but I decided to pursue nephrology instead. I've done lots of research on long-term outcomes of preterms, including neurodevelopmental assessments. But when I looked into this and when I studied your preterm follow-up guideline, and the word blood pressure is mentioned, I think once. So fortunately, it's there. But I was just wondering, most of those follow-up studies focus on neurodevelopment, and understandably, that's the most important concern for most parents. But the long-term risks, especially those with AKI, their long-term cardiovascular risk is really pronounced. And I was just wondering how you are planning to incorporate that in your guideline, if blood pressures are part of your standard follow-up schedules, and how we can improve the awareness among neonatologists, among pediatricians, that it is so important to assess the long-term cardiovascular risk of especially those extremely preterm.
Gosh, cardiovascular risk is something that I am concerned about. We have late adolescents and outcome data, topic for another talk, where we track their blood pressures, and their blood pressures are higher, and the disparity is getting greater when from 18 to 25. I am concerned. At 8, we did not find any differences in blood pressure between the preterms and the controls, just out of interest. Yes, blood pressure is important. Yes, it was mentioned there. We did have general pediatricians on the working group that did highlight the importance. In terms of the follow-up, you will see general health up there. We haven't forgotten about general health. Neurodevelopment is important. It is not the most important. I'd like to think of it as part of the general suite of what we called it growth, health, and development, not just neurodevelopment. So yes, blood pressure is important. This guideline takes it to school entry. We don't have enough data to talk about, to recommend more assessments from a cardiovascular kidney perspective just yet. However, we are very well aware that people are getting increasingly concerned about the kidneys, and let's wait for the data to come out to give us more direction and guidance as to what follow-up needs to be done apart from measuring blood pressure. You will notice that we did not recommend invasive blood tests or urine tests at this age because we just don't have the data. So we recognize the importance.
I respectfully disagree that there is not enough data, because I think there is heaps of data that the small for gestational age, the children with AKI, that there is a 1 in 10 risk of developing chronic kidney disease in those groups. So 1 in 10, that means that a lot of these kids have incidental signs of a higher cardiovascular risk. And I've done research myself in teenagers where there is not hypertension, but their blood pressure is 1 standard deviation higher than their term-born controls. So I'm not sure which data you are waiting for, because it is out there that there is an increased risk, and I'm very happy to share those data with you, or to be part of your working group to raise awareness about the long-term cardiovascular risk.
I think we can have a discussion about the strength of evidence that has to go into national standard guidelines. And that is a discussion for another day. But I do respectfully take your point from that perspective.
Thank you.
Yes, thank you. I'll go to the next. So if there's Flora's got a comment. Does the project include follow-up and audit on the implementation? Not the initial project, Flora. because this was really delivered after a few months after the funding ended for the previous CRE. But now that we've got another CRE, I'm kind of hoping that we will be able to incorporate that into that cycle. The implementation is difficult. We decided not to have a general recommendation for implementation across the country because every jurisdiction has its own challenges. So for now, we are taking the strategy of individuals to supporting sites. And it's nice that we've been able to do that sort of at our side. I see Jen Walsh on the call. So Jen Walsh is my colleague at the Women's, and she really sort of has led the project here. So thank you, Jen. Very proud of her. But hopefully we can share some of the learnings to support other sites implementing this. Brooke says, thank you. Victor's got two questions.
Questions to ask. I was going to say, yes. Sam, yeah, thank you, Sam.
Hi, Jeanie. We are looking forward to your visit in April for the parties in Singapore.
So am I.
Yeah. Okay, my questions are, there are many from the low middle income countries in this audience. And many of these standard developmental assessment tests are very expensive. Like for Singapore, like to do a Bailey and, or Wechsler scale at 5 years or later assessment, it costs nearly $600, excluding consultation. That means nearly $700. So all these tests for all the babies, ELBW babies, are they needed? Or can you do something like ASQ and so forth and screen out, a pediatrician or a neonatologist, can do the assessment, can rule out cerebral palsy and other things easily, and do the standard Bailey or the Wechsler scale at 5 years, only for the selected group.
Sam, I mean, I think you hit the nail on the head. So one of the points I made was flexibility, and on the slide where I talked about implementation at our own hospital, we can't see everyone in person. So there's always the thought about, can you screen and then select those who need to be seen? So I absolutely agree. So this guideline, I do apologize. I realize there are international attendees today. It's an NHMRC, Australian NHMRC endorsed guideline. So it was specifically targeted for our population. However, the principles are still there. And I would think that it should be able to be adapted to local conditions. So you are right. Bailey assessments are expensive. You need staff, you need money, you need resources to be able to do that. And not everywhere can do that. But yes, you can get access to a questionnaire for screening. And then those who screen as high risk, you bring them in, or you do whatever you can within the confines of resources. And at the end of the day, it's really to make sure people don't forget to check at those ages with those children. I think that's the way I see it. I think when people think about follow-up, they think, oh, you're not going to come in for a half-day assessment. That's not follow-up. Follow-up is making sure that you check in. Now, what levels of follow-up you provide, that really has to have so many factors involved. Does that answer your question, Sam?
Yeah, it does, but there are, a lot of challenges.
I don't disagree.
Yeah.
And I'm not saying, and it's a challenge, but I think if we as a community of neonatal pediatricians, we spend so much time, effort, and resources in the NICU, I would think that it would be such a shame, almost irresponsible, if we didn't find ways to optimize outcomes longer term by seeing how we can provide better evidence-based structured care after they go home. That's just my approach.
My other question is, what about 32 to 36 weeks? You know, you have stressed about the problems of late preterm. I have read your articles, you know, and some hypoglycemia guys, they say, oh, that cohort also need to be followed up. So much so, we end up in following up, you know, very high-risk babies. I tell you, 30 outpatient clinics, you know, per week for our doctors. That drains us out sometimes.
So I think each jurisdiction has to determine what their priority groups are. Even though this guideline was devised for very preterm children, you will see a lot of the domains are very broad. And I think any child who has been sick, who potentially has a long-standing impact on either their health and or development and or blood pressure, can follow the principles of this guideline, but who gets in person, who gets more often and less often, I think you have to work out within your own organization what resources you have and how you can deliver them. Remember, there's telehealth services. Okay, it's not free, but it is probably less expensive than bringing the person in to see them for a half hour, an hour, 2 hour appointment. Thanks, Sam. I see another question. Okay. Talk about advocating. Thank you, Mental. Advocacy was one of the things we would hope that this guideline would be able to provide the different centers. 4 to 5 years, unachievable, resource limited parts in the top end. Absolutely agree. I do not believe we out little people will have access to. If there are there any, at best we can only do Griffiths. Is this acceptable? We can talk more, Mantho. The guideline is not about what is acceptable and what is not. It's about what is recommended. Actually, I didn't go into detail, but as part of the guideline, we do have a list of assessments that are used. We didn't want to recommend, so some have got an asterisk to say that they are recommended because they're more broadly used. But the working group did recognize that, you know, developmental assessments, different ones are used throughout the country. So yes, Griffiths is used very widely in some parts of Australia. There's nothing wrong with that. So long as you have some formal way of assessing development. And yes, you know, if you can't get psychologists, you are challenged from a resource perspective, then, you know, how else can you deliver? There are questionnaire screens. Once again, there are screening questionnaires. So I fully appreciate that point. That was something that we discussed at every working group meeting. And I hope that helps, but send me an email if you want to have more of a discussion.
Okay, so we are coming to the end of the hour, Jeanie. Thank you so much. Look, I mean, Mentos raised a really good question because, you know, the highest risk areas of preterm births are usually the ones with the lowest capacity for providing care. So it's something that we as a global community need to address because we're so focused on saving tinier and tinier and tinier babies that we sometimes forget about the other people, the 28-weekers, the moderate to late preterms that we have no resources left for. So I guess we should have a magic pot of gold and give you all the money so you can tell us what we need to do. I guess before we leave, Sam has one last comment. If the Bailey scores at 2 are normal, can we, I suppose he means ship, Sam, not skip, not ship, the formal testing of IQ at 5 years?
Sam, there are many studies that show that the developmental assessment at 2 years, even the cognitive scores of the Bailey or the MDI of the Griffiths, is not strongly associated with cognitive ability at 5. So if you do have the resources for the highest risk groups, you will be surprised that you will still find challenges if you are able to provide a cognitive test at 5 years. If we were so confident about 2-year developmental assessments, then we wouldn't be bothered to do them later on. But as we have followed the children up, the older the better, I think is the saying. But you can, once again, it's back to not being a purist, not saying all or none. These are the recommendations. What can we do within the confines of the available resources? So that's step one. And step two is, how can we then advocate to try and get more resources? I mean, there's never enough resources, but how can you advocate, or we devise the system to be able to accommodate at least a little bit more? It's not easy, but if we don't aim for the best practice, we will always be providing suboptimal care.
Thanks for the wise words. Yeah, thank you. Yeah.
Okay, thanks everyone.
Thank you, everyone. Thank you, Jeanie. The
No worries.
recording will be there to share, hopefully. No one's doing anything weird in the background. So thank you again and have a great week. Bye, everyone. Bye.